Thank you, everybody, for giving up your lunch hour. We're going to go through some of the key questions that you're going to have about the bivalent vaccine. I'm joined by Rockstar. I don't think I've been called a rock star. My kids definitely don't call me a rock star. So Peter Lynn is here to join with me. Peter is an expert on a lot of these topics as well. So we're thrilled that you've given up your time. We're going to talk about bivalent boosters. We were originally going to talk a little bit about a variety of things, but we're going to focus on bivalent because that's the new news that you need to know to be able to counsel your patients. We wanted to talk about patient questions. So we've actually divvied up the presentation as if you're getting questions from your patients and providing you some of the context of how you can address those within your clinical practice. Peter and I do a lot of continuing educations. Those are Peter's disclosures. I think Peter's the only one that I know that has more disclosures than I do, which are my disclosures are here, except where it says presenter. My name is Mike, so it's there as well. So in terms of our learning objectives, we're going to discuss the importance of boosters in maintaining COVID-19 protection and really talk a lot about that role of the bivalent booster and why that's required with the Omicron variant. We'll look at some of the key considerations for administering a COVID-19 booster, some of the questions you're going to get about, well, I've had an active infection or I just got my fourth dose of my booster. What do I do at that point? And then how you can answer your patients' questions regarding the role and the safety of COVID-19 boosters. So let's turn it over to Peter. So Peter, the first question we're getting, I'm taking this fictitious patient. I've called her Karen because she has lots of questions, but she says, isn't COVID gone? Why do I need to worry about boosters?
Yeah, so Mike, according to you, okay, COVID is not gone, but according to the media, it's gone because there's no headlines anymore or anything like that. And by the way, for those that don't know, Mike has become, I guess, our national and perhaps international expert on COVID. He reads every single piece of data. So if there's any data questions directed at Mike, and he will know the answers for sure. And so this is the perception, is that it's gone. And that's what the government would like us to think, is that it's gone. You start living with it. People are not dying, so therefore everything is good. That's actually not quite true, because if you look at the numbers all over the country, so anything that's in dark blue is where it is high numbers. So for example, pretty much most of the country is still in this dark blue area. And so therefore we have lots of cases. Now these are reported cases. And so you can see on the right side here, the reported cases have come down. This was the big, huge Omicron spike that we saw around the beginning of the year. And then you see the numbers coming down. And if you're looking at a graph, you're saying everything is in perfect control, except these are the reported cases, right? Most of the people are doing testing on their own at home. So they're doing the home test. So that doesn't get reported anywhere. We've had a lot of patients where they'll test themselves. And if the rest of the family gets sick, they just assume that it's going to be COVID. So they're not even testing some of those people. So let's say it's a family of 4, we'll miss all 4 of those people in that the data collection that we're doing. And so therefore, I think the government has lulled themselves into, don't worry about it. The experts are saying that we have to take whatever their number is for the daily cases and multiply it by 10. So if they report 1,000 cases, then probably it's closer to 10,000 cases that we're talking about. So that gives you a sense. So if we were to report, 10,000, 20,000, 30,000, or in Japan, 200,000 cases, people might pay attention. But right now you don't hear any reports at all because that data is not being captured anywhere. If you look at the science data, the Ontario Science Group, that's been dismantled. So they were providing us good information. It might not be what politically sounds good, but then in terms of scientifically, it was sounding good. The web page is still alive right now in terms of what information is populating. The 2 things that they've highlighted here is hospitalization and the other one is intensive care unit. And of course, you can look up death data as well there. And so from the government's perspective, as long as the hospital has capacity, then we're okay. Now, I don't think that's a good way to treat any disease. So imagine if we said, okay, let's not treat heart attacks because we have capacity to treat those heart attack patients. And so therefore, let's just let them have heart attacks because we have capacity. And the goal is not to protect the hospital capacity. The goal is to protect patients. But they always say the same thing. Our hospital capacity is good. It seems like we're trying to protect the hospital, but we're really trying to protect people. And all those people that test positive that can't go to work, flight attendants, people that work in restaurants and stuff like that, will not show up in this statistic. So they're not in hospital and they didn't die. And yet the economy is getting killed because they're not able to work, et cetera. So anytime that you have a place where there's not enough employees, you should think, is this because of COVID? And most of the time it is. And so therefore it has a huge impact on us as well. So Mike, here's another thing that she might say to you. I heard Omicron is very mild. So I don't need to have a booster. It's just like a cold, and that's all it is. And evolution says that the virus will become like a cold, and so why are you fretting?
Yeah, and I think that's a key question. And we've also a variant of the same question is it's like they'll come up to you and go, dude, I've already had this. It wasn't a big deal. I was fine in a couple of days. Everything is okay. But let's take a look at the numbers. And Peter's shown a little bit there. So we have this high caseload, but we also have a high hospitalization. So remember when Delta was, everything was hitting last year. And if you look at the July numbers from last year, look at what our hospitalization rate was. It was actually almost zero. Like we had so few people within the hospital that we weren't worried about it. We still had restrictions in place. We were still really worried about the stuff. Now come in July and our numbers really haven't gone down. And this is where Omicron has really led to significant increase in hospitalizations in comparison to previous waves. And you can see that consistently within this graph. The concern that I have, and I really flagged it here, is we're still losing about 200, well, this one was 260 weekly deaths. This is, what we're losing, people every single day associated with COVID-19. This is not something that's just gone away, that these people are completely clear. But we know that the data is pointing out, and this was data that was released within the CDC, is that 1 in 5 people that catch COVID as an adult is likely to have long-term impairment that's associated with this in some form or another. So one of the key people that we work, Peter and I work with, is Dr. David Strain out of the UK, and his concern, he's mentioned this a variety of times, is that there may be a long list of health concerns that are associated with this pandemic post this pandemic, where patients are coming with cardiovascular conditions, metabolic conditions, respiratory conditions that are associated with their COVID-19. What we also know is that every time that this patient gets a reinfection, you get it once, your risk of long COVID is this amount. You get it twice, it goes by this amount. 3 times, it just keeps going up. So anything that we can do to prevent these reinfections could reduce the risk and the impact of long COVID on our patients. But in kids, it's really quite scary in terms of what Omicron has done. We've talked about kids, and this isn't a pediatric talk, but I just wanted to spend a couple of seconds on this slide. It's just looking at, we heard at the beginning of the pandemic, kids are safe, they don't get anything, don't worry about it. What we do know is with Omicron, and as the kids have gone back to school, there's a high transmissibility of this one, and we see an increase in hospitalization. This is data that was published in the US. The risk of hospitalization was 5 times higher with Omicron for pediatrics than during the Delta. And everybody thinks about Delta as, ooh, this was a really bad wave. Omicron has had this huge impact. And although we're seeing less severe outcomes on the individual level, when more people get sick, higher risk for those people to actually have those severe outcomes. Long COVID, UK is doing some incredible data. We know that about 3% of the UK population, 3% have some symptoms of long COVID from the previous infection. But what we know is about 1 in 50 kids in primary school, so that's up to grade 6, nearly 1 in 20 in high school have long COVID type symptoms that are associated with it. And this could be that cognitive fog, this could be a decrease in physical activity ability, this could be tachycardia, a variety of different symptoms that these patients could be experiencing. My worry with these kids, really, really concerning with the kids, is this is the time when you're from 1 to 6, is that your brain is such a sponge that should be soaking up all of that information. And if you have any of this cognitive impairment during that time, what is that going to lead to these kids long term? And we just don't know at this point. And that's some of the key concerns that we have in terms of long COVID. And in terms of Omicron causing issues in older adults, you can see in terms of some of this is likely due to a decrease in terms of vaccine efficacy in our older adults. As we started to move away and we ended up having these new variants that have come in, we're having an increase in terms of hospitalization rate ratio for older adults for a lot of these individuals, even though they're a highly immunized population. So it's really showing us a potential need for a change in terms of our vaccine strategy that could really address Omicron. And this is something that's quite different than what we've seen with previous variants in the past. So Peter, I've heard this so many times from people. It's like, Mike, why do I need to get 4 shots? That's a lot. Like, this is like a ton. And, I've already had 3. And the funny part with this is I've also said is like, nobody ever thinks about this on a milligram basis. Like, it is at most 100 or 50 micrograms. They have no idea what kind of concept. Is that a lot or is that a little? It's a tiny amount, but they're really kind of worried about getting this 4th shot. What would you do to address this type of question in practice?
Yeah, I think the problem is that this vaccine was being given out to protect people at the same time that they were figuring out how many shots it needs. Like, for example, hepatitis B, we know it's 3 shots, right? So we tell people it's 3 shots, and nobody has a problem the fact that it's 3 shots. The new malaria shot that they're talking about right now is going to be 3 priming and then 1 boost. and those 4 shots is what you need. But that's because they had time to actually do the studies and all that kind of stuff and look over the time frame. Whereas with this one, it was get it out, protect people as fast as you can, and then we'll figure out how many shots you need to give you protection. And then the virus was changing at the same time. And so therefore, those are the 2 variables that are there. And I think that's why people are a little disappointed, because I think in the beginning, it was promised to them 2 shots, you're done, freedom, like you can travel, you can do whatever you want. But reality is that most of our vaccines will need more than 2 shots. And so therefore, at that part, I don't think we explained very well at all. In terms of why do you need all these shots? So when it was Delta, 2 shots was actually not bad. And I'll show you the data around that in a second. When Omicron came along, then we said, I think we need another boost, as Mike was talking about the waning of the antibodies that we make. So therefore, 3 shots became the norm. So where did this 3-shot data come from? So a lot of it comes from the UK, because they've been tracking everything. They're also the ones that are the most relaxed, I guess, if you will, in terms of generating viruses. But at the same time, they're also tracking things for us. So this is after 2 dosages of this one. Okay, so this in this particular case, it was Pfizer 2 dosages. And they looked at Omicron and Delta in terms of the effectiveness. So perfect would be 100% effective. So if you can have dots that sit up here, that would be great. And this is over time in terms of weeks. And so what you could see here is the black dots are Delta. And so over time, you could see that there is a dropping off at about 6 months or so after 2 shots. So in other words, your body makes antibodies, and eventually after 6 months or so, your body's going to say, do we still need to make all these antibodies? And the reason for that is because in nature, we shouldn't see this virus again. In other words, your body fought it off, you made antibodies, you don't need to carry them forever because probably you're not going to meet this virus again. Unfortunately, we travel and we keep passing this stupid virus around, so it's coming back around on us again. But the body doesn't want to continue to make antibodies that it doesn't need. And so therefore, there should be a dropping off of it naturally. With Omicron, you could see that the drop off is a little bit quicker. And so therefore, you have a little less to begin with, and then probably the antibodies are dropping off, and therefore the efficacy may be dropping off. So what happens if I give you a booster, the 3rd shot? So what we could do is take this point, and then we can send it up for Delta, and then we can get you right back up to close to that 100% mark. With Omicron, we can take you from down here, which is quite low, and then we can send you upward. It will drop off over time, but this is going to be a better position for people. So that's why a booster with the original vaccines that we have is going to give you some more antibodies and therefore give you better protection. What about if after 2 shots of Pfizer, you went ahead and did a Moderna shot? And remember, people were worried about mixing and matching and things like that. So again, you can take this person and you can send them up here, and then for Delta, it's going to be very good. And for Omicron, you can take them from down here and send them upwards. And there will be a little decay, but nonetheless, this will be in better position. So that's why the 3rd shot was recommended at that time to protect our people. Now, where did this 4th shot come in? So the 4th shot came in and said, okay, I think we need another shot because Omicron is going to be a little bit more difficult and a little more challenging. And so where's the data around there? And I thought I'd show you this set. There's many sets of data, but this is looking at the neutralization, the one that grabs the tip, the business end. So those antibodies are important because they're the ones that go into the ACE2 receptor. So if you can grab that end, that's probably the best you can ever do. Although if I can grab anywhere on the virus, it would be good because you can tag it and get rid of it. But let's just look at the neutralizing one. And here is where, again, these are the 4th shot of the original vaccine. Okay, so nothing to do with the new version or anything like that. And so this is looking at what happens with the wild type, the original virus. What about the Delta and what about Omicron? Let's just focus in on Omicron. Okay, so let's just look at that one. So this is the titer that they have, 12 units or whatever it is that's there. What would happen? This is 5 months after your 3rd dose. So after your 3rd dose, you still have antibodies, but it's going to be a little bit lower than before. Now, what happens if you were to get a 4th shot? What number does that go to? So 1 week after your 4th dose, so that number now goes up to 107. So you can see that's a huge jump that goes up in this direction. And what happens if you let your body have 2 weeks? So here's 2 weeks after 4th dose, you're now at 136. So you can see that we can take somebody from 12 up to 136. So that's 10 times increase with 1 shot after 2 weeks. So that 4th shot was able to give you things. And this is the original vaccine. So it's nothing special about it. We're just giving you the same one, allowing your body to create the antibodies again. It's like retraining your body again, sort of saying, here's another go at it, so to speak. Now, what is your risk of dying? And Mike pulled this out from some archive. I don't know where he finds all these wonderful data. But this is the risk of dying. And let me just show you what the graphs are. So this is unvaccinated people has the highest risk of dying. And then down here, this one, you guessed it, is the 4-shot people. Okay, so if you have 4 of the original shots, then your risk of dying is now 42%, 42 times different between these two groups. So therefore, we could say it one of two ways. This group is 42 times higher risk of these people dying, or we could say that you could reduce your risk by that amount as well. So whichever way your patients like to hear it, I think that's useful. What about if you have 2 shots or if you had 3 shots? So let's look at the 3-shot people. So there's a lot of people said, I've got 3 shots already. Do I really need the 4th shot? So the difference between 3 shots and 4 shots, it doesn't look big here, only because this guy is disproportionately swinging the graph away. But this little drop right here is 4-fold risk of dying. So imagine if I said, okay, here's an ACE inhibitor, and it will change your risk of dying by 4 times. I think everybody would be taking that ACE inhibitor, right? So even though we say 4 times, and it looks small, but if you think about, we're talking about dying, if any other medication was in that position, I think we would say that has to be part of the guidelines. Now, the other thing is that people were saying that the antibodies are not sticky to Omicron. In other words, Omicron is evading. Now, if that is the case, then we should get infected, and then we should end up in hospital. Okay, so let's look at the infection rates. Now, the problem with infection is that I cannot get antibodies into your nose. Okay, so that one we have to talk about sprays and stuff like that. But in terms of giving you an injection here, I have antibodies on the inside, but I don't have a whole lot sitting in your nose. So therefore, people are going to get infected. So the orange line is unvaccinated people. The blue line is vaccinated with at least 2 dosages. And you could see that we were getting Omicron. So whether you were vaccinated or not, people can get infected. And that's because the virus just needs the cells in your nose. It doesn't really need to go anywhere else. It just uses those cells to replicate. Now, if the antibodies were not working, then we should see a replica of this graph in terms of hospitalization. So in other words, the 2 things should go up and down at the same time. Because if I'm vaccinated and my antibodies don't work, then I'm like as if I'm unvaccinated. So the curve should be almost matching like this. And what you see here is you see that disconnect, right? So the people that are unvaccinated are ending up in hospital, but the people that are vaccinated are not ending up in hospital at the same rate. There are some that do, and I would love to test your blood and see were they ones that responded and made antibodies, because we know there are people that don't respond to vaccines. For hepatitis B, for example, we have all these surgeons where we inject them and then we check them afterwards and they just don't make antibodies. So they're just missing the B cell or whatever so that they can't produce those antibodies. So I would love to know if these people didn't have any antibodies and that's why they ended up in hospital. But you can see this huge disconnect is no longer the same as this. So that means that those vaccines that we got were protecting us from Omicron, from invasive disease. What about the intensive care? We see the same disconnect here as well. So in other words, I think when we say that the antibodies aren't working, we just have to be careful because it is working because those people are not getting sick and ending up in hospital. This is another question, Nate. Like, how can the original shot give me protection? So I think, Mike, you've answered this a million times. I'm going to give a shot at it. So let me give it a try. So one of the things that I was thinking about is that the spike protein has to fit into the ACE2 receptor, okay? So no matter how it mutates, it has to have some features so that it can go into the ACE2 receptor. So that means Omicron or whatever cron comes next cannot completely mutate because otherwise it doesn't fit the receptor. So that means there will be some commonality amongst all of these spike proteins, otherwise it won't fit the receptor. So therefore, if there's commonality, then could we make antibodies that go after that commonality and therefore be able to protect you against multiple things? And that might explain why I gave you the original Wuhan virus shot, and yet it was giving some protection to the Omicron and people didn't end up in hospital, okay? And so this gets us away from the idea, excuse me, I don't have COVID, I just had a tickle. So this gives us the idea that maybe the way we explain things to patients was not quite correct. We said, we give you the shot and you make an antibody, one antibody. I think that's what patients have, right? I give you the shot, you make one antibody. But that's not true, right? I give you a shot and you may make multiple antibodies to that spike protein. Some of them may be to common spots that also show up in other versions of the virus. And maybe that's why we're able to see this sort of spread across to the other strains, some protection. Now, this data I'm going to show you. So Mike is always ahead of the game. He shows you data that just got published. I'm going to show you data that was published like around 2020, and it actually hit the news wires on February 2021. And these people were from the original vaccine studies. So the original Pfizer and the original Moderna studies, they took 20 people and they had their blood samples. And so what they did was they said from the original 2 shots that they got of the original vaccine, they looked at the types of antibodies that they made and they categorized them here. So these are the antibodies that these 20 people made. They didn't all make them. So some made ones and some made the other ones. And then what they did was they looked at all the point mutations that they had been collecting. So these are all the mutations that the spike protein has been going through, these amino acid changes. And so what they said was that, does the antibody from these people go against these things? And let me just show you how this works. So the N501Y, so that means that in position of the amino acid 501, the N amino acid was replaced by the Y amino acid. Okay, they don't use the names of the amino acids because it's too long, so they just give them alphabet numbers now. And then so in this mutation, those antibodies that we're looking at here, how much do you need to block it 50% or to block it by 90%? In other words, bind onto it. So you could see that if we have nice and low numbers, that means we don't need a whole lot of antibody. So that's a good thing, okay? So that means that that antibody is still working. If we see things like over 1,000, that means I'm pouring antibody on there and nothing is sticking. So therefore, that's no good. That means that that antibody is no longer effective, okay? So what I did was I went through this whole table and I actually highlighted all the over 1,000s, okay? So in all these areas, those antibodies are no longer useful. So if you're looking down this one, then you know that this one's not going to work, this one's not going to work, and so on and so forth. What's interesting is that this is the wild type. This is the original thing that we showed you in the vaccine. And you could see that all the people made antibodies and all those antibodies are good. There is no over 1,000 here. So if I show you that spike protein, you're going to make antibodies against that spike protein. What's interesting is that it also got people to make it against this mutation. It also got people to make it against this mutation, and this mutation, all from that original shot. So this concept of one shot, one antibody is wrong. It's one shot, multiple antibodies, some of which will be good against certain changes in that spike protein. I want to show you one other way to look at this table, and that's sideways. So if you look at a specific antibody, so this specific antibody you will see right across has no red. That means that all these different mutations, it doesn't affect this antibody. So it means that it's binding onto a site that is not affected by these changes that I just listed here. That's starting to think like that common part against all of these strains. Here's another one of them. So it's not just one magical one, and here's another one of them. And so this all came from that original shot, right? So 2 shots, and you're making this soup of antibodies that you're doing. Now, the amount might be different, right? So you might make more of one versus the other, but nonetheless, you're able to produce. And this may begin to explain why, if we keep using the same shot, we're still able to give you extra Omicron ones and so on and so forth. And so that's why this concept is very useful for people to understand. How can I get that vaccine and still get protection for the newer versions of these strains? So Mike, why do I need an Omicron specific booster now? Okay, so yeah, okay, I get it that if I have one, I can make all sorts of stuff. But why do I need an Omicron specific one in the mix?
And the way you explained that, Peter, was great. It's just that we look at it, if you only have 3, where before you had 20, you need a lot of those 3 to actually offer the same benefit. And that's one of the reasons why I think that we're getting the breakthrough infections with some of these mutations, specifically looking at Omicron. With the Omicron booster, if you look at Omicron in comparison to the others, it's a mess. Like, look at on the right-hand side of this image. There's over 50 mutations that are associated with the 30 of them in the spike protein itself, 15 within the receptor binding domain. It's across all of these here. So it is a different animal. And CDC last week actually presented, if you're a real geek about this stuff, they did a talk about cartography of this virus, and they presented it at their meeting at ACIP last week. And they looked at it and said, looking at Omicron versus previous variants or the ancestral strain wild type that was there, if you give it an arbitrary number and they say, you know what, the difference between Omicron and wild type is 7. If we were to look at influenza, a difference of 4 would mean a completely different strain that would have to be put within that vaccine. So it is really surprising that our current boosters offered any protection against Omicron. So it's quite exciting, and this is one of the reasons why we still have to come up with something new that we've done within this bivalent booster. So I describe it, I watch Christmas Vacation with my kids every single year. I'm old, so you know what, if you've watched the movie before, we have on the Griswolds that are here on the side, these are your standard bases. This is your gamma, delta, alpha, beta. And if you're familiar with the movie, you have Cousin Eddie and his family. Although they're related, they are very, very, very different. And if you want to deal with Cousin Eddie, you need probably a very different tool than what you would have to deal with in terms of the original Griswold. So different strategy, and this is why it's quite different from anything that we've dealt in the past. And that's why this bivalent has been introduced. So the difference here is when patients said, well, why didn't we do one for this for Delta? Why Omicron? Because Omicron has been the game changer. It is so different from what we've done in the past that we need to actually do protection. Either we boost every 3 months, which is what we've been doing so far to offer that protection and maintain that protection over that period of time, or looking at a different tool and what we can do from there. So this is a paper that was published in the New England, and I'll kind of talk you through from left-hand side to right-hand side. So on day one, this was actually looking at patients that haven't had vaccines. And if you look at 1 month after the second dose, and this compared ancestral type and wild type, and the amount of patients that had neutralizing antibodies after the second dose, 1 month after, 100% were protective against wild type, 85% against Omicron. But if you look 7 months after the second dose before the second booster, this is why we needed to boost, because you can see that 100% of patients maintain their protection against wild type, but only 55% of those patients have protection against Omicron during that time. We boosted 1 month after, you can see 100% of the patients maintain the protection, but then 6 months after that booster dose, you can see that the Omicron protection had waned quite a bit, still had 100% protection, but it started to wane over that period of time. And this is actually showing the same thing. And you see where that green arrow is. This is a booster 6 months post dose 2, and they give the booster at that point. And then the half-life of the neutralizing antibodies, the antibodies in there are decaying at well, this one 6.3-fold in terms of a decrease in terms of the overall fold of it. The half-life is actually it's significantly quicker in terms of what we see with Omicron versus the original wild type. So this is the reason why we need those ongoing boosters to maintain that protection, or look at it a totally different strategy than what we've done currently. And this was some of the data that was published at the CDC last week. And this is why we kind of need that new strategy. So they looked at immunocompetent patients, all adults, looking at hospitalization. This is what's here. And this was during the BA2 and the BA4, BA5 phase. So from the BA2 phase, you can see that at 4 doses and then the days after, 7 to 59 days after, it still had about 80% vaccine effectiveness at maintaining that protection. But for the BA4, BA5, we look at that bottom line in the bottom part of the graph at 60 to 119 days. You can see the drop off in terms of 4 doses, in terms of vaccine effectiveness, and greater than 150 days, which is 2 doses, we're going around that 20% vaccine effectiveness at actually reducing the risk of hospitalization. So before we thought, you know, Omicron patients were getting breakthrough cases, but in terms of vaccine effectiveness for severe outcomes, hospitalization, ICU, and death, it was still holding up fairly well. But we're starting to see some of the data. So the longer that we go away from those booster doses, that decrease in effectiveness is occurring. And that's assuming, again, this is, again, immunocompetent patients 18 years and above. But what about those patients who are 65 and above, who have that immunosenescence, or many of our patients with chronic conditions who don't produce the same antibody titers as what patients without those conditions would be? So those are our highest risk patients, and they may be the ones that are actually not getting that vaccine effectiveness. So really points to need for a new strategy, and this is why we're coming out with these bivalent vaccines. So I like this picture. I picked it out. It's kind of the glamour, the glitz, the glow off of it, and we're moving to this bivalent vaccine option. And you know what, with here is what is in this new booster. So what is this new booster is the key thing. So what we did with this is the way that the booster and way the vaccine is made is you take a small piece of mRNA, you put it within a lipid nanoparticle that's injected, it goes into the cell's ribosomes make the spike protein, presented on the outside of the cell surface, goes to lymph nodes, you generate the antibodies. What they did this time is they took 25 micrograms of ancestral RNA strains, the same as what we would see within the previous booster or in the vaccine dose, And then they gave 25 micrograms of the Omicron spike protein specific. This one is 32 of those mutations that we see on this graph are mapped to BA1 are within that 25 micrograms that are included within it. And it's designed to specifically match Omicron. And this is this mRNA 1273. 1273 is the original vaccine. .214 is for this version of it, which is a BA1 version of their booster. Why the two sets are there is that we want to not just boost Omicron, because that's important, but we want to actually give a breadth of protection. So if you think about the Griswolds and you think of Eddie and his family, we don't only want to just protect against Eddie and his family, but what happens if we get a strain that's related to the Griswolds again? So we need to boost this as well. So that's why there's two different components within this. And the goal here is to really give a really broader and more durable protection against any of the strains that we currently have circulating, but also what we may see moving forward. So it's all about past, current, and future. And that's why these bivalent vaccines have been introduced. So Peter, the question that everybody here, I'm sure, is on this call looking at is really, does this actual vaccine work? And I'm sure that's what every patient has been asking about.
Yeah, and I think that's a good question. So in the beginning, we thought, okay, mixing the two things together, is it going to confuse the body? What's going to happen? Is there going to be a boosting effect? Is it going to increase all antibodies, or is the body going to get confused? So therefore, we have to do the studies to look at it. And to your point, Mike, by putting the two together, there is actually a hope that your body recognizes certain things. So for example, let's say you saw the original one. So you made a whole bunch of antibodies. You made that soup. Some of them are the good ones, and some of them are just, to parts that aren't so useful. Now, if I show you another spike protein, your body will say, hey, I recognize that part. And so therefore, those cells will start to produce. And if those cells start to produce, then they're making an antibody that will now recognize both spike proteins. And so the concept of showing you two isn't so much that you're going to make against the different parts. We're actually hoping that you'll make against the common parts. The three that Mike pointed out that went across, maybe that will actually get your body to preferentially produce those three, as opposed to making a whole bunch to cover the whole thing. So maybe that's going to happen, but we won't know that for some time. But what we do know is, do we increase the antibody levels? So that's what they always start off with. There are antibody titers, and then we're hoping that those antibody titers, more antibodies, more weapons that you can fight off the virus, the better protection. So let's just look at the antibodies, the neutralizing, and this is looking specifically at the Omicron version in terms of grabbing that tip. And so just to point out that these scales are crazy, they're in 10-time multiple, so logs. So even though the graphs don't look too far apart, they're actually quite big differences here. So let's give you the original shot, and that 1273 is the number of amino acids in the spike protein. So that's where that number comes from. So that's the original wild version of it, and they're going to give 50 micrograms of it. And so you could see that you take somebody that has their previous shot, their priming shots, and now what you could do is you can make their number go up almost 4 times. So therefore, that shot is going to be helpful even if you're giving the original one. And remember, these are neutralizing for Omicron. Now, what about if we give the bivalent one? So the bivalent one, as Mike pointed out, has the decimal behind it. So that means there's 2 components to it. And so what you could see is that they start off around the same, but then now the number is much higher. And so you could see that you have more Omicron neutralizing antibodies by using the bivalent version. Again, the two graphs look really close to each other, but if you look at this one, this is like 2,000, this is like 3,000. So imagine if I said, okay, I'm going to give you a bonus of $2,000 or $3,000. Which bonus would you like to have? I think we'd all go for the 3,000. Now that's everybody. What about the seronegative? So they've never been infected before. Do they get a nice boost? And there you can see that their antibody titers were lower, and then we can now send it quite high. So again, about 4 times or so with the original shot. And then with the bivalent version, again, you get bigger numbers here, 1,400 versus 2,300. And so therefore, this looks like the bivalent makes a whole lot of sense. What about for people that have been infected? We had a lot of people that said, I've already had the infection, I don't need anything else. So if you look at the seropositive people, they've already had an infection. The first thing I want you to notice is that their baseline antibody levels are really high. So it's higher than everybody. So if they paid the penalty of getting infected, yes, they do have more antibodies. Unfortunately, they're at risk of long COVID and all that kind of stuff, but nonetheless, they do have more antibodies. So the question was, could you increase that? So even if you give them the original shot, again, you can increase that. But if you give them the bivalent, you could see that it increases quite a bit more. So the bivalent in a seropositive person has the highest antibody levels at 7,600. And so that's why the bivalent makes sense for people that have had infection. Interestingly, if we give you the vaccine and you've already had an infection, so you've already been strong against whichever version of the virus that you had, now we're showing you 2 more spike proteins. So maybe your body now will be able to recognize the common part much easier. Right now, we don't separate out the types of antibodies that you make. Is it binding to the common part or is it binding to a special part? We don't usually separate that out in trials, but you can imagine that if I show you 3 different spike proteins, eventually you're going to figure out, hey, this part is the same in all of them, and that's the one that I'm going to make antibodies against. So therefore, the bivalent one in general, the .214 version, will always give you higher titers. And again, this is looking at the Omicron version. What about against these other versions that Mike was talking about? So the relatives that haven't been visiting but could visit, so alpha, beta, delta, gamma, and you could see that there is a nice boost in terms of all of those areas. So this is the original vaccine that you give, you will get a boost, but then here's the bivalent and you will get a boost. So you're going to get coverage that it's more broad. So that's why Mike was talking about broadening out the coverage with the bivalent, and perhaps more durable because we're giving you more antibodies on top of that. So Mike, I heard in the US they're getting a different booster. It's all over the news. So it's like iPhones now, you know, iPhone 5, 4, 3, whatever. So should I wait for that one? Should I go to the States and visit my cousin down there? And I was very worried that those were your relatives. And then you pointed out that it was from a movie. So that's
Japanese movie. So this is a question that Barb has actually asked within the Q&A is, what do we do here? And what about BA4, BA5? And if you look at the actual what's spreading within North America right now, it's not BA1. So BA1 is actually not spreading, it's actually BA5 is that we see as a predominant strain that's actually circulating within North America. So for those of you that are not familiar, we actually see that BA4, BA5 is the one that the US has actually chosen for their bivalent vaccine, whereas within Canada and Europe, we're using BA1. But if you look at the data that's here, and this is again all looking at neutralizing antibodies of all participants, when we actually looked at protection against BA4, BA5, you can see that jump in terms of the antibody levels for patients actually they've received the 214 dosing. So just like what we saw with the previous wild type original booster providing protection against a broad range of variants, this is the same as what we're seeing here with Omicron. We're really targeting that family. So remember, think about Cousin Eddie. We're targeting everybody within that family. So it's so different, but they're close enough in terms of BA4, BA5 to BA1, BA2 that we're actually offering a breadth of protection against those individuals. So we have many of the mutations that we're seeing within BA1, BA2 are also within BA4, BA5. And as Peter mentioned before, is that patients who actually had Omicron, this is a significant amount of our patients that we see within practice. You can see the difference in terms of the overall antibody for levels for patients for prior infection. The concern is should we be waiting for this one? Are we going to be coming out with this? And the fundamental issue is we probably won't have a BA4, BA5 here within Canada, and we can't get caught up with chasing the individual variants. So what we're seeing now within the US is actually a decrease in the amount of BA5 as a percentage of the overall cases. And we may see within the fall and winter time a prevalence or an increase of BA2.75, which is a variant that started within India or was originally discovered within India. If that is the case, the BA1, BA2 may provide more robust or broader protection against this BA2.75 than if we were to get the bivalent with a BA4, BA5. So my advice to all of you and advice to all your patients is that what we want to do is actually give what we currently end up having. This vaccine is going to offer way more robust protection against all of the subvariants that we've currently seen to date of Omicron. And as Peter showed, not only about Omicron, but everything we've seen to date. And what's interesting is that last graph that Peter showed is not only did the bivalent increase the dosing of all previous variants, but that bivalent at a lower dose actually had a booster higher levels of GMTs or antibody levels for all previous variants than if we'd given the original booster. So this is significantly better than what we've seen in the past and will offer your patients protection against BA4, BA5. So comfortably recommend this option for those patients. So remember, as I just mentioned, it's not about chasing the latest variants. It's really about providing robust protection. We want to have, again, David has mentioned that we want to look at having an antibody soup that we're presenting to our patients. We want to have the most complex soup that's there. So no matter what we come in contact with, what variant of this this horrific virus that we come in contact with, that we'll have antibodies that will offer some level of protection against. And that's what we're really focusing on. Peter, safety. I think a lot of people are worried about that one as well.
Yeah, I had a lot of patients say, so if there's two things in it, am I going to get double sickness? Or, I mean, that's a good question, right? And so therefore, of course, we have to do the studies. And to Mike's point is that broadening out, I think, is the important thing. I think the problem is, I think patients heard one shot, one antibody. So if we can say one shot, multiple antibodies, then I think they understand that that's going to be better than no booster shot, and therefore their antibody levels will go down. So I think that's going to be a very useful thing for you as well. In terms of side effects, you know, they have the grading and the shading. So the shaded ones is a little bit more severe, and the dark color one is the little bit milder version of things. And this is systemic side effects. So these are the ones that people worry about: fever and fatigue and muscle aches and those kinds of things. And so the way they put this graph is that these are the second dose of the original version. This is the third dose of the original version, and this is the bivalent. So the one in the dark blue is the one that you're looking for if you're trying to recommend a bivalent to your patient. So look for the dark blue column. And so if you look at fever, for example, it is not higher. And that's important for us, because if we're giving you another shot and there's two things in it, I think most patients are going to think that there's going to be higher. And what about all the other areas? And I just want to point out, I'll use myalgia, for example. You'll notice that the myalgia for the bivalent is, if anything, it's going to be slightly lower. And if you look at the hashed areas, for example, it's smaller than the other hashed areas, and that would be the grade 3 side effects. So we don't see anything strange that all of a sudden you get more side effects or anything. If anything, it's going to be on the low side of things. And if you look at the local reactions of pain and things like that, nothing is higher than the previous shot. So if they were okay on the previous shots, then there shouldn't be any unusual symptoms there. No strange signals came out, so people didn't grow horns or anything like that. No vaccine-related deaths, but mind you, it's a small study. So as we roll this out, first of all, in the clinical trials, there's no increased strangeness. In other words, there's no mixing that, you know, for some reason, if we put in 2 mRNAs, anything else is worse off. So nothing new has popped up in terms of the safety side of things. So I think that's very reassuring for patients, especially as they're going on as well. So Mike, should I get this new booster? So what's the final conclusions of all of these?
How many times have we said it like that? This one, yes, these patients should get this new booster. This is just makes sense. So the question is, should I get it? NACI is coming out with recommendations. So we had approval for this one last week. The same day, NACI actually published a statement on September the 4th, and it was right after approval within Canada. In this one, it covers epidemiological update, hybrid immunity, seroprevalence, benefits, efficacy, safety. All of it is covered within this. So if you can't remember anything from this webinar today, go here. You can find almost everything you end up needing. So this is what I was saying. Like, if you look at the concern in terms of an epidemiology update, if you look at BA1, BA2, and this is where a lot of patients are concerning, look, it's not really that prevalent that's here. It's all BA5 is what we're typically seeing, with some BA4 that's across the board. But the fundamental issue here is, again, we're targeting the breadthness of Omicron and not really specific subvariant of Omicron. So this is the reason why that we wanted to actually look at getting this out here and getting our patients protected as quick as possible. So effectiveness of original booster, this is directly from the NACI statement. We're seeing a decrease in vaccine effectiveness of the currently available vaccine boosters against Omicron compared to every other variant of concern. So all the strategies we've done so far, everything has worked against every previous variant of concern, and that's been consistent with the data. Approximately 60% shortly after receipt of the booster, you see a decrease in terms of the vaccine effectiveness in most of these over time. So we'll start to see that decrease that appears for most of our patients. And the initial vaccine effectiveness against severe disease, although initially 90% after the first booster dose, but it remains up to 75% up to 26 weeks after that first booster in most of the studies. But as we're seeing with some of the studies I showed you from the CDC in the US, that seems to be dropping off a little bit quicker. And that's why we're coming up with this new strategy. So what are NACI's recommendations? So first and foremost, all individuals 12 years of age and older who are at increased risk of severe illness, they're all listed here on the side. Sorry for the small text, should be offered a fall COVID-19 vaccine booster, regardless of the number of booster doses previously received. The way I would describe it is the way the CDC described it in the US. Think about the fall with our COVID strategy as a reset. We're resetting our strategy to look at a quite different virus. So looking at this Omicron. So complete reset, no matter what you did before, no matter how many doses you had before, as long as you completed your original series, then we will be moving and transitioning towards these bivalent boosters. NACI also recommends that all other individuals 12 to 64 years of age may be offered. So you see the difference in terminology, should versus may. So should, or anyone at high risk of actually having severe outcomes, may be offered. And as most of you know, what Ontario does is whatever NACI says, Ontario typically does whatever they want to do, and this has been consistent with every province. They just pick and choose. We're going to see a strategy, and we have enough of this bivalent booster for anyone or any adult who wants to actually receive this booster will be able to receive it. NACI recommends that the authorized dose of bivalent Omicron mRNA vaccine should be offered as a booster dose to the authorized ages of 18 years of age and older. If it is not available, then the mRNA COVID vaccine can be the original vaccine. So mRNA 1273 could be offered to ensure protection. And that should not be the case. We have enough of this 214 to offer everybody. One of the key things here that I want to just specifically call out is before, between the group of 18 to 30, NACI originally said, no, we shouldn't be using Moderna for that age group. We should be using Pfizer only. You can see that the difference here is now this vaccine, this Moderna-specific vaccine, can be used in 18 years of age and older. So that preferential recommendations for these bivalent boosters has been removed. And it can be considered for 12 to 17 with moderate to severe immunocompromising conditions or who have biological social factors in place them at high risk of severe disease. So the guidelines are now coming out clearly that these are the patients that should receive it. Highest risk patients first, but likely will be almost all of us as this reset comes in play. Co-administration, a key concern for pharmacists. No participation and persistence of the bivalent clinical trials were concurrently administered other vaccines. NACI continues to recommend any vaccine that the patient is eligible for should be received as long as they're 5 years of age and older. And this would include influenza vaccines. So if you have your patients sitting in their chair, influenza in one arm, COVID-19 bivalent booster within the other is completely acceptable. No decrease in efficacy. No real changes in terms of overall safety, and higher chance that patients are going to receive both doses. And the question came up, and I saw this within chat, is how long should we wait? NACI was pretty clear. So they said 6 months after a previous COVID vaccine dose or a SARS-CoV-2 infection, and that's how long you should wait before you receive your next booster. But just like what we saw in Ontario, NACI says one thing, Ontario says something different. A shorter interval of less than 3 months, or at least 3 months, could be considered if the risk is quite high, because we remember these patients drop off fairly quickly. So we want to boost it if there's a lot of virus circulating within the community. So to finish off our key learning points, and then we'll get to the questions that are there, the pandemic numbers are still high. We are likely to have a major fall surge in numbers. And as the kiddies have gone back to school, like we see every year when the kids go back to school, we'll see an increase in respiratory type of infections. We can't think of Omicron as a mild variant. We have to really work on our patients to say this is not mild. This is significant. Higher infectivity led to higher hospitalizations than all the other current waves. Our original boosters offer some protection, but it really wanes, and specifically wanes with Omicron. The bivalent booster will offer protection not only against Omicron, so BA1, but BA4, BA5, but also every other previous variant. So it is giving a breadth of antibody soup to actually offer our protections. And NACI recommends a bivalent booster for all adults and adolescents with immunocompromising conditions. So one of the questions before, I'll turn some of these over to Peter as well, that comes up is somebody was asking, what about infectivity data? So they were looking at, we have antibody data, and we don't have really any other in terms of outcome data as being one of the key concerns. What we're seeing with all the boosters moving forward is what we're going to be doing is with what we do with influenza. The WHO comes out and says, these are the strains you need to put in. Each of the manufacturers will come up and make a flu shot with those individual strains. They don't do clinical studies within those, for each of those individual strains. We're going to see this also with COVID-19, where we're going to actually have boosters that are going to be put in place. They're not going to have to test them in a large portion of patients to get them improved. But observational studies are going to be ongoing. What we do know with all previous variants, high antibody levels led to high improvement in terms of overall outcomes, lower risk of hospitalization, lower risk of severe outcomes, and ICU admission and death. So if it mimics, which we fully anticipate it will, then this is the reason why we don't have necessarily data now, but likely that's what's going to lead to the overall course. In terms of other questions, So just wondering, okay, that was antibody. Can we expect data on the Omicron boosters for 5 to 11 years of age? Does one wait to boost their original vaccine, which is the kids ineligible to receive the COVID vaccine in 16 months? Any thoughts on that, Peter?
Yeah, I mean, they're all going to be working on it, but the kids are always delayed, right? So
Yeah.
they always do the adult first, and then once they finish up with the adults, then they'll do that. But it also, once you understand that the original vaccine, so the boostering for the original vaccine is still useful. In other words, we will still make stuff. And I guess I've been telling patients, it's kind of like when you buy a bag of screws. You have lots of different screws. Some, are maybe too long, too short, or whatever, but at least you have lots of screws. So when you get that original shot, you will get a batch of antibodies. So even though the bivalent isn't available for the kids yet, at least get them fully loaded in terms of that. And the second reason is because if their body is able to recognize the original spike protein, then when I show them the new one, I'm hoping that they're going to say, hey, this part is common, and then ramp up production specifically for that antibody that may be going across the two versions, and then maybe that's going across multiple versions as well. Because remember, that spike protein cannot mutate to the point where it can't go into the ACE2 receptor. So that means there's common parts to it, and that's the common part that we'd like your body to recognize. Now, ideally, I've been asking some of these companies, can't you just figure out the common part? Right? Like just look at the stupid pocket for ACE2, and it's got to touch these points or else the key doesn't work. So it's kind of like a master key. That's really what we're looking for. So ultimately, we may not give you the whole spike protein mRNA. We may give you an mRNA that produces a weird shape thing that would fit the pocket, and then you make antibodies against that. So that might be the future of this pan vaccine that we're talking about. So instead of, they've been talking about putting 20 different mRNAs in there. I don't think that's the strategy, right? The strategy is to go for the commonality as opposed to making an antibody for this little change and that little change, because we want to be the most efficient with your body, right? We're going to ask your body to make flu antibodies. You're going to ask your body to make meningitis antibodies. We're going to ask your body to make a lot of different antibodies. And I don't want to have to make a whole soup. It'd be ideal if we can find the commonality that's there. And that's really what's going to happen when we start doing these two shots. The original concept came from actually way back in Singapore. They had 10 people that had the original SARS-1 virus, and then they gave them the current mRNA. So they saw the original spike protein from SARS-1. They then saw the new spike protein, the wild version, and their body was able to recognize that common part, because once your immune cells recognizes and says, I know that part, I've seen it before, I saw it 20 years ago, I'm going to start making weapons against it. So preferentially, they made the common part. And then when they tested their blood against alpha, beta, gamma, and then 2 from bats that we haven't seen yet, and 3 from pangolin animals that we haven't seen in humans yet, it worked against all of them. And that's because it was going after the common part of that spike protein. So that's why when people say, I got to have a lot of my patients go, oh, we're getting the BA1, so I'll forget that. We're on to 5. It makes it sound like the 1 is useless. It's not useless, because what we're doing is we're training your body to find the commonality. And so therefore, I think the commonality part is going to be the one that gives you that broadening of it, as opposed to giving you 55 different shots all at the same time.
So good question, Peter, that came up, and I'll take this one on. It's would you recommend boosters for those at low risk of hospitalization or death, and is there any impact in terms of vaccines on long COVID? So first and foremost, would I recommend it for low risk? Low risk is actually what we know that from the patients that have it, those are the patients that are low risk are the patients that are actually working, right? So these are usually the young people that take in the TTC. So I'm thinking about my own kids who are at university now, and everybody's sitting together. They're at high risk of actually getting the infection. We know the more they get infected, the higher the risk of complications associated with COVID itself. In terms of impact of the vaccines on long COVID, we only have observational data. This comes from the UK, is tracking. They're doing the most work on long COVID. They're citing numbers based on their data showing that vaccination in comparison to unvaccinated patients is about a 42% reduction in the risk of long COVID. Not strongest data, but there is some data here that actually can offer that benefit. One of the questions here, Peter, that came up is, what if is it okay if my patient gets all 4 doses of Pfizer or all 4 doses of Moderna?
Yeah, it's fine. It's fine, because what we're doing is we're showing you the spike protein. Both of them are good. There is slight difference in terms of the beginning because of the dosages, right? So for the Pfizer one, it was 30 micrograms of the mRNA, whereas for the Moderna 2 original shots was 100 micrograms. So there was an actual dosage difference. And so therefore that dosage difference means that you may have more antibodies. And that's what they showed, is that in the original data, there is more antibodies coming off of the Moderna one. And also perhaps the antibodies might last longer because you have more antibodies. And there is some data, if you go and search the New England Journal of Medicine, they have data saying that there may be better protection. So if you have more antibodies, you have more better protection. And that's why for our transplant people in Toronto, the recommendation is that for the third shot, if you're a transplant patient, that you should be getting the 100 micrograms of the Moderna because it'll give you a better bump up. Now that we're talking about boostering, so Pfizer's booster is 30 and Moderna is down to 50. So now they're much closer to each other. So in the boostering one, it probably won't make a whole lot of difference. But in that original block, I think we saw that. That also might explain why some people say there might be a little bit more side effect, because with the Moderna at 100 units, you might have a little bit more side effect than compared to, let's say, a 30 of the Pfizer. So that might also explain some of the increased side effects that some people were talking about at the beginning.
So the last question I think we'll have time for is just looking at myocarditis risk. And that's a question that comes up from every healthcare professional across the board. So I'll just do a quick stab at it from, you have to look in terms of myocarditis risk with mRNA vaccines in terms of the risk with COVID-19 versus getting the vaccine. What we do know is that the risk factors for myocarditis, the highest risk groups is between 18 to 24. So in that age group, there is an increase in terms of myocarditis risk in the patients that actually receive the second dose of the primary series using Moderna, but not seen with the Pfizer and the two studies that were there. And this is one of the reasons why initially for primary series, second dose, the Pfizer had a preferential basis. If you look at the broad-based group across everybody, Moderna is looking at 250 million doses that have been given of Moderna mRNA 1273. The risk of myocarditis across the entire population of people that are there is not that above what is expected. So from the standpoint of, is it a little bit concerning within 1824? Yes, but even in the kids that ended up, or the adults, young adults that ended up getting this myocarditis during that time, if they were vaccinated, it usually led to good outcomes. These patients were typically managed in the hospital, given an NSAID, discharged with no long-term outcomes. That's not necessarily the case with if they actually had myocarditis associated with COVID-19. So from the basis of this one, it's not like I'm going to get this one and my kid's going to end up having a heart issue. If they get COVID-19, they're a much higher risk of developing a heart issue associated with it. And what we've seen is that's really with the secondary dose. Although we don't know that much from the third dose yet, that data is still being tracked, but everything looks in terms of previous boosters that risk factor has been relatively lower. I think Siva has asked a question about kids. I actually just did a webinar yesterday with a pediatrician and the cardiologist that sick kids said they're not really worried about myocarditis risk in the young kiddos. It just doesn't seem to be an issue. It's really that specifically in males. I don't know what's wrong with us during that 18 to 24 age group, but there's something there that is actually leading to that overall increased risk.
It's testosterone, Mike. I think there's a testosterone effect. But to be all honest and serious for a second, Peter Liu's group up in Ottawa in cardiology, they are tracking myocarditis right now. So they have a huge registry that they're tracking. And there's going to be a small component which will do genomics on these people. In other words, what is different about these people out of 100,000 people, these 16 people or whatever that they would get myocarditis versus the rest of the people. So it might be kind of like, when people are allergic to peanuts, right? The peanut itself is not a problem. It's the person is allergic to the peanut. And so I think that's the direction that I'm hoping that they're going to take that registry in. And as Mike pointed out, the vaccine-related myocarditis, very mild. There's no long-term complications. There's no heart failure or anything like that. Whereas the disease version, it is quite bad. And we do know that same age group of the males, for any viral myocarditis, they're at a higher risk. So there is something going on. I don't know. I'm jokingly, I was talking about testosterone, but there is something special about that group. Forget about the vaccine. Just viral myocarditis in general seems to be higher in that group. And maybe with the registry and everything else, we're going to find that out because we've seen that pattern before, but it just happens so rarely that nobody really tried to figure out why males have more myocarditis with a virus infection. But maybe now, because of the vaccination program, we will actually figure that one out at the same time.
And I tell everybody, I have 3 boys within that same age group. All of my boys have actually received both doses. I just cannot take the risk knowing the impact of what COVID-19 can have on the heart. And I'm worried about more long-term what the cardiovascular impact if they were to get repeated infections of COVID-19. So I would still encourage that they get it. I think on that note, I think we're running a little bit over time. Ruth,
Oh, that's okay. I think there was a lot of questions. The one thing I wanted to bring up is that you mentioned about giving a flu shot and a COVID shot in 2 different arms. I think we're kind of moving towards giving the both of them in the same arm at the same time. Well, not exactly the same time, but at the same. But you just have to be really careful that you landmark properly. We're going to talk about that at another webinar coming soon to you from OPA. But I really want to thank you so much. There was so much information here. Really, really appreciate all your in-depth work on this. And it's not going to go away. We're going to keep talking about it, and we're going to have to keep talking about it. So, and I appreciate both of your time and everyone who showed up. It's just great to see everybody. So I just wanted to say thank you again, and thanks to Moderna, and keep coming back to all the other webinars. And I'll hear you on TV, on radio, Peter.
Yeah, you try to turn it off.
No, I love to hear the way
that crazy guy again.
Yeah.
Oh, and don't forget mask and distance. Okay, the next 2 weeks, 2 weeks is high risk. Okay, everybody's getting back together, coming indoors. So tell everybody that you see, please, the next 2 to 3 weeks, we can stop wave 8. Okay, everybody keeps predicting this horrible wave. We can stop wave 8. Just by
prove us wrong. That's what everybody asks. Prove us wrong. Like we don't want to see it.
I'd love it.
Exactly. Take care, everybody, and have a great day.
Thanks, everyone.
Okay, bye-bye.
Thanks. Take care. Bye-bye now.
Bye.